Hello, everyone. I am Breana. I am one of the genetic counselors with KK Women's and Children's Hospital, and I will be your moderator for this session this afternoon. So before we start off the session, I'd like to get everyone to look towards the screens and sign into Pigeonhole so that you can submit any questions that come up as the speakers are speaking. Do this throughout the conversations that we are having so that we would be able to identify the questions that are top of people's minds. All right, so you can either send in your questions or vote through that platform on the questions that you would like to see answered later on in the Q&A section. Okay, so before we start, I would like to introduce our first speaker. Ms. Yasmin Bylstra is the Senior Principal Genetic Counselor at SingHealth Duke and US Institute of Precision Medicine. And she leads the development and delivery of clinical genetic services for population genomics screening. And she's also practicing within the cardiology and ophthalmology settings here in Singapore. She's also PhD candidate, and her interest is in characterizing genetic disease prevalence, as well as exploring the acceptability of genomic screening amongst Asian populations. So please put your hands together to welcome Yasmin, who will be giving us a talk on genomic screening initiatives that are tailored to the Singaporean community.
So thank you very much for the opportunity to share my experience, which has been working with both patient and population data sets to tailor genomic screening initiatives in the Singaporean community. So I arrived in Singapore almost 13 years ago, and I was involved with variant curation very early on in my role here. And this was during the time before ancestry-specific genomic data sets were available, and even before 1,000 genomes. So variant curation at that time was particularly challenging. And in the clinical setting, I had patients who would ask how prevalent their genetic condition was, or what was the chance of having a child with a genetic condition. And I would look in literature, but there wasn't very much available regarding individuals of Chinese, Malay, or Indian ancestry. And at the same time, there was emerging recognition that the lack of diversity in genomic data sets was also producing inequity in different health settings. So my colleagues started collating genomic data from control population data sets. And the first was 831 exomes. It's a really small number comparison to what's been discussed at this conference, but we did find something significant and managed to publish. So we looked at 80 treatable inherited conditions and found that the prevalence of citrin deficiency and Wilson disease was more than expected. And this led to an understanding that patients were possibly undiagnosed with these conditions, so it led to an awareness, and also the inclusion of citrin deficiency in newborn screening. We then had access to 1,750 genomes with detailed phenotypes, and this came from healthy individuals, and they were healthy because they were excluded if they were found to have some sort of health condition during their health examination. So this then led to the development of a framework to develop clinically relevant results. So we developed a framework which had this learning environment where we could transition results found under research into the clinical setting. Patients consented to access medical records, and then they opted to have results of genomic findings returned. And there was only very few who declined this. We would then review genomic information and the clinical information in a multidisciplinary team. We would invite specialists according to the condition that we were discussing, so ophthalmologists or cardiologists. And this was a learning environment where we could discuss how the variant was classified, the clinical care pathway for that particular patient, and it would also raise awareness of potential referrals as well to the specialist clinics. So out of 1,750 genomes, we identified 33 participants who had a monogenic risk. Of these, 25 and attended an appointment to receive results. We then offer clinical validation and 16 pursued with this. So I often get asked what's it like and how participants respond to receiving this information when they don't have any associated health conditions. So I thought I'd share some of these stories with you. So the first is a participant who was found to have 2 ATP7B variants. This is associated with Wilson disease. We did some clinical testing and he was found to have abnormal copper levels, and parental testing also demonstrated that these variants were on separate copies of the gene. He was recommended treatment for his copper levels, and we also hope this then will alleviate some of his experiences of anxiety and depression, as these can also be associated with Wilson disease. At the appointment, I start by collecting family history, and this participant shared that their father had had a diagnosis of colorectal cancer and had been to the cancer genetics clinic, and he was found to carry an MSH2 variant associated with Lynch syndrome. So she knew that she was at 50% risk, but had decided not to proceed with predictive testing. So this put me in a very difficult position, because in my hand I had a research report saying she was a carrier of MSH2. So I wasn't quite sure what to do. I decided to just review what types of information we're looking at with this genomic testing, and then disclose that we'd found under research she was also an MSH2 carrier. Thankfully, she excuse me, responded quite well to this information. She said that she'd been thinking a lot about predictive testing, and this disclosure had kind of removed that, the fact that she had to make this choice. And she was quite relieved now to hear what her risk was. We also had a participant who was found to have a Casein Q1 variant associated with long QT. And he was really happy when I gave him this result, which was unexpected. And he said it was because he'd had an abnormal ECG many years ago, and had tried to follow up after that with screening, but he was told that subsequent screening was normal. So he found that this genomic variant now helped him access the care that he needed. We also had a LDLR carrier associated with familial hypercholesterolemia who had really high cholesterol levels. And he said that's because he'd stopped taking statins. It happened to be simvastatin, because he experienced very painful muscular pains. He was found, we were able to share with him that this was because of his pharmacogenomic profile, and that should he be prescribed another statin, that he most likely wouldn't have the same response. And lastly, we saw a couple where one was a LDLR carrier and the second was a carrier of MYH7 associated with hypertrophic cardiomyopathy. They have 3 children, and this then inferred that their children had a 75% of cardiac risk, and also a 25% of inheriting both of these conditions. So I had access to the medical records of this cohort, so I was interested to see if they were following the screening advice that was recommended for their condition. And I found that only out of the 25, only 5, there was documentation that their genetic result had been discussed with a healthcare professional. And this is despite us giving information about the appointment in a summary letter, and also referrals which specify the genetic variant detected. And additionally, there was only one family who came for predictive testing, and again, this was despite family communication letters provided and no cost to the testing as well. So I think this is really interesting, and I've been looking at this further with qualitative interviews. So then we had access to SG10K data, and this allowed us to look at the prevalence of genetic conditions within the Singapore population. So we analysed variants of 4,114 genes associated with Mendelian disease. With this, we're able to look at the genetic conditions which are associated with clinically actionable genes. And we found that the most prevalent were Titin, LDLR, and BRCA. This is not so surprising. However, when we look at the prevalence amongst the ancestries, we found that they were quite different, and some were also driven by a recurrent variant. So, for instance, Chinese in grey, familial hypercholesterolemia was more prevalent. Indian in orange, these are 2 heart conditions which are prevalent. And in Malay, these were the conditions that were more prevalent. So having this, the understanding the prevalence of genetic conditions in the Singaporean population now means that we have a better understanding of the chance of a condition being genetic. And this is the example for familial hypercholesterolemia, where the prevalence at the time was higher than expected. We also then worked with an external research institute to return clinically actionable findings. This occurred during COVID, so I believe that this impacted the response. We were also able to look at the prevalence of recessive conditions in the Singaporean population, and focusing on those associated with severe paediatric conditions and a high prevalence, so more than 1 in 200 in the population. We found that there were 7 that were unavailable in commercial panels at the time of analysis. So this has now led to the development of a carrier screening panel for the Singaporean population, which includes recessive conditions which are prevalent amongst Chinese, Indian and Malay. We've kept it small, so 112 genes, so that it is more affordable, and therefore hopefully it will be more widely accessible. And there's currently funding to screen 39,000 couples, and this is around the number of births in Singapore per year. We are also interested in understanding the views from the community regarding carrier screening. And we've also engaged, we've also engaged with religious leaders in Singapore as well. And they've all been very supportive of carrier screening, and then they have different views regarding the family planning options available. I wanted to share some of the results from the questionnaire that we have. It's very preliminary, 38 responses. We ask, have they had carrier screening in the past? And 26% say that they have. When I look at the conditions, it's all for thalassemia. This is the condition which is routinely offered in Singapore at the moment. They're also asked, are they interested in participating in carrier screening? And the majority said that they were moderately to extremely interested. They're also asked, would they be willing to pay for this carrier screening test? Because obviously cost is a big has a big impact on uptake. And 41% said that they would prefer no cost but would still be willing to do the test, and the rest said that they'd be willing to pay $200 to $1,000. They were also asked that if they were found to be at risk of having a child with a severe genetic condition, what pregnancy management options would they consider? And the majority said that they would consider options such as testing during pregnancy, PGT, and also termination of pregnancy. I also found it was interesting, if you look at the second bar, it says if my partner and I were a carrier couple, I would decide not to have any more children, and also the majority agreed with this response as well. So now when I see a patient in my clinic who has a recessive condition and they ask what the chances were that their parents were carriers of the same condition, they always think it's 1 in a million and they're the only one in Singapore. But now I can give them a better answer and say that it's actually more common than what they think. I'm also able to give them information about the chance of having a genetic condition, a child with the same genetic condition as them. We also found that there were recurrent variants in the Singapore population that were more frequent than in public databases such as Nomad. And this is really important, also particularly from patient populations, as it can open up opportunities for clinical trials, as currently gene therapies are generally targeted towards variants which are more common in the European populations. So now we're just starting to have access to SG100K, where again we will be returning clinically actionable results. We will be looking at 45 genes associated with Lynch syndrome, BRCA and cardiology. And we've already identified over 300 participants at monogenic risk, and we will be commencing to return these very shortly. So I hope that I've demonstrated to you that ancestry-specific genomic data is very valuable for genetic screening, but also as my practice as a genetic counsellor in Singapore as well. Many people have contributed to these work. I've just listed the ones that I work with very closely. Thank you.
Thank you, Yasmin. And next up we have Marianne Young. So Marianne is a leader in the genomic health provision in Australasia, and she has a special interest in research contributing to the evidence of patient experiences in the use of new genomic technologies and translation of genomics in clinical care. She is the head of Clinical Translation and Engagement Platform at the Garvan Institute of Medical Research. And so let's welcome Marianne to give her talk about a cutting-edge translational program having impact in returning genomic research results.
Thanks, Breana. Thank you. Thanks for the organisers for inviting me to give this presentation today. We've heard a lot during this great conference about big cohorts being developed, and now they're at the stage where they have actionable information that they wish to return to research participants. And I just wanted to present to you today our Australian experience of returning results to research participants, particularly a platform that we have set up in Australia that's led by genetic counsellors to facilitate the return of results. And that platform is called My Research Results. So just for some background, probably everybody's aware, but we know that with large research populations that the use of genomic sequencing is going up and up. And that means that there's an increase in the likelihood of actually finding an actionable mutation. And for those of you who may not be aware, you can either actively look for a clinically actionable result, or it can incidentally arise when the analysis is being done. When you actively look, that can be called opportunistic screening. Or they, as I said, they can arise in incidentally. And depending on the cohort, about 1 to 6% of people are found to have a clinically actionable result. And most of these people don't know that they have it. So I think it's really important to think about why return results in the first place and why this is such a big topic of conversation. As I said, it's important that people have the opportunity to know. Some may not want to know, and I think Yasmin actually showed that in her data that some people may not want to know. But the people have an opportunity to know because they may not be aware that they're at high risk of a disease that is actually able to be reduced or prevented. And also secondarily to that, it enables cascade screening in their relatives. And this is about disease prevention. And it's to improve the health of families and individuals. Because we know that for many of these actionable genes that are returned, there are evidence-based risk management strategies that people can engage in to reduce morbidity and mortality from disease. So, whilst there's been ongoing debate, I think the horse has bolted now, and it's not should we, it's how will we return these results. I think the conversation's moved quite along. And it's now standard practice to actually return the results. I think the focus should be now on how do we best do that to support people in actually making a decision about whether they wish to receive those results and how they go about receiving them. I think the thing to say is it's very context dependent, and it depends on the cohort that you're returning the results to. If it's a paediatric cohort, it's very different compared to an adult cohort. It depends on how the research was undertaken, and I'll talk to you about some of the cohorts that we deal with. And is this the genomic research? Is it just a sub-study of a larger population-based study? And were the people recruited a long time ago? There are many organisations that have put out guidelines with regards to returning results, including the American College of Medical Genetics, GA4GH. In Australia, we do have guidelines put out by the National Health and Medical Research Foundation, and they say that researchers doing genomic research must have what they call an ethically defensible plan. So if they are doing genomic research, what are they going to do when these results come up? And they say that if participants wish to know, they must be provided with genetic counselling. So I'll now just quickly take you through on what the data shows with regards to research participants and researchers. Most research participants, and of course this is in European populations, and so I think it's really important to think about cultural specific issues in regards to returning results, but most people prefer to know. And the more actionable the result is, the more likely the person is to want to know. And it doesn't matter if you ask biobank participants or patients, if it's hypothetical or actual, that people want to know. And in America, there's data starting to emerge that some people actually see it as a prerequisite to actually taking part in the research. So I'll give you something if you give me something back. Other people become concerned because they say, well, we might harm people psychologically by giving this information back. And to date, there's no evidence of psychological harm. We know that immediately when you tell people they're unaware, it's unexpected, they have feelings of shock. But then many people talk about the value of the information, and at 4 to 6 weeks post telling them, they actually value that information and have spoken to their family about it. And people even use words like they feel empowered by having this information. What do we know about the uptake? And I think it's very different and it's country dependent. I think it depends on the health system. I think it depends on the how many genetic counsellors and medical geneticists there are. And I think that it's very dependent on the way you actually tell people, and that's what we experienced in Australia. But you can see there's wide variation in regards to uptake. What do we know about family communication? I am a genetic counsellor, so I'll say that up front, but we know that it's much more effective when a genetic counsellor actually works with people in passing on the results, and they are much more likely to talk about it with their family when a genetic counsellor discloses the results. We know that most people actually do talk to their family about it as well. What do researchers think? Researchers also agree that giving back results is an important part of their work, but they don't have the skills, they don't have the resources, and they don't have the expertise in talking to people about this. So I'll just take you to Australia. You've probably seen a couple of maps of Australia during this conference. It's a big country. And I was laughing, it took me about 8 hours to get here, and the first 6 was actually flying over Australia, out of my country. Most of our population live around the seaboard. Access for some people is difficult because people live far from services. We have a population of about 25.5 million, of which 4% are First Nations Australians. And we also have a large multicultural population with nearly 30% of our population born overseas. But you can see, there are lots of people who live in coastal regions and they live far from major cities. And that's important in thinking about how we set this service up. So back in 2013, I had the opportunity to undertake some research with women who had ovarian cancer, or if they died, their next of kin, in giving back research results to them. And then we did research, and what we identified in that research is that they had unmet needs and unmet information and support needs. And we felt that genetic counsellors, when we went back and looked at the literature, genetic counsellors were the ideal group to be talking to people about this information. And that was because genetic counsellors have experience and skills in communicating risk information, but more importantly, they can talk to people about family communication, which is an important part of this if you are thinking about disease prevention. And they can also advocate for people. So we identified that there was this gap in Australia, so we set up this platform called My Research Results. And it's evidence-based. We use a notification system, which I'll tell you about, and we work with researchers to actually facilitate the return of results to research participants. And we return primary research findings, and we also return secondary research findings. And so what we do is we connect the researcher and the participant to the genetic service if they choose to hear their result. So we have 2 functions. We actually provide a service. So we have a fee for service. We get paid for this if we work with researchers to provide the information back to their research participants. But we also have a research function as well, and I'd really encourage any of you who are thinking about starting to give back results as part of your projects to think about having a research arm to giving back the results. And we're focused on looking at how people adapt to the result, how do they think about the result from a utility point of view, from both a clinical and a personal utility point of view. We're doing some health economics analysis and looking also at Australian research participant preferences about secondary findings. So how do we do it? It's quite simple. Once the variant's been identified, and that goes through a genomics multidisciplinary meeting, we write them a letter and we put a stamp on the letter and we send it in the post. Now many people think, wow, I don't get many letters these days, but that's how we do it. In that letter, we say to them, you took part in this research project, and we name the project, and you said you wanted to be notified if we found anything that might impact the health of you and your family. It's likely we've found something. If you'd like to know more about it, please call this number. And at the end of that telephone is a genetic counsellor. And most people call within the first 24 hours. We can always tell when a batch of results go out because the phone starts ringing. We also say in the letter, if you don't call us, we'll call you in 2 weeks just to make sure you got the letter. And so that's what we do. We call them in 2 weeks. And we provide telephone genetic counselling, and we refer people on then to clinical genetic services to have confirmatory testing, because this is a research result. And we don't just stop there. We keep in touch with people and manage their expectations and help them navigate the complex health system to get into a genetic service, because we have waiting times in Australia of 6 to 12 months, and people fall through the cracks and they fall off. And so we keep in touch with them every few months just to see how it's going. And we also continue the conversation about their family. So to date, we've given back 354 results. And you can see these are the cohorts, but all around Australia we've given back these results. And the good thing about it is that doing it by telephone, we can reach people in the farthest parts of Australia. The average age of participants that we've given the results back to is 48, but as old as 93. We had a cohort that was called the Welderly. They were old people, they were all above 80, and they were ascertained on the basis of an aspirin study. And they all wanted their results back to pass on to their family members. We do give results to next of kin. Most of the people we've spoken to so far have been the proband, but we do give results back to next of kin, and we are actually doing some research into how next of kin feel receiving that sort of letter. And you can see the gender breakdown there. Here are the results that we've returned. And again, a bit like Yasmin, the familial cancer, they're the greatest amount of results. We have returned a lot of renal cancer results, and that was because the cohort was ascertained on the basis of renal cancer. But you can see hereditary breast and ovarian cancer, Lynch syndrome, and again, familial hypercholesterolemia, a very undiagnosed condition. Just thinking about, Professor Tan made a comment earlier in the symposium about precision value, and one of the important things to think about with this type of work is the health economics. So we're actually doing a micro-costing project at the moment, and we're going to be able to give researchers a cost for a positive participant or a negative participant of actually returning those results. And we're also going to look at cost to health system. And another important thing that we need to know about is what is the clinical outcomes for these people? How many of them go on to continue on with the screening and the risk management they're recommended to have? And how many of their family members come for predictive testing? So I thought I'd put some tips for any researcher who's considering returning results. And I'd say it is current practice to return results, and if you don't return results, that's probably a bit out of practice. But you have to think about the healthcare system that those people are going into as well, because some countries may not have the health system to be able to provide the ongoing risk management that's required, and it's very important. Understand the rationale and why you're returning these results. You're not just doing it because it's actually people say you should. You're actually doing it to prevent disease and reduce morbidity and mortality. And also consider the context within which you are returning those results. If it's a paediatric context, it's quite different. So we're returning results to a large paediatric cohort at the moment, their primary results for cerebral palsy, and we're returning those to the parents of those children. We have another, I'll just tell you about some of our cohorts. We had another cohort, 200,000 people who were ascertained on the basis of having a diagnosis of breast or prostate cancer, some who were recruited 20 years ago, that we're going back and telling them that they carry these variants. So, you know, context is really, really important as to how these people. I would highly recommend that you involve a genetic health professional from the start when you are conceptualising your project. and embed them in the research, or use a platform like we've developed, which is a centralised platform. Genetic counsellors will help you write the protocol. They can help with the HREC application, and they're the best at writing consent forms. And they can coordinate the return of results process for researchers, and they can actually disclose the results to the family in a way that is supportive to the family. The other thing I was thinking about was be agile. So some projects, we're working with a large Parkinson's disease trial in Australia at the moment, and I wrote their ethically defensible plan 5 years ago, and we're only now starting to return the results. So it can be quite a long time before you actually get to the end where you do return the results. And the other tip is actually embed a research program into the return of results program as well. So if anybody would like any more information about it, please feel free to contact us, get the QR code, or we have a website as well. I'm not spruiking. This is something that we're doing in Australia. But if anyone would like to know more about it, please feel free to make contact, and thank you.
Thanks, Marianne. And so now we have our third speaker for today. So it gives me great pleasure to introduce Sook, who is the head of genetic counselling at the Cancer Research Malaysia. And she is also, let me see. I'm sorry, I'm blind. So she is also the president of the Genetic Counselling Society in Malaysia, and through the society, she actively works to increase awareness of genetic tests and genetic counselling in Malaysia. So today she'll be speaking to us on genetic counselling care pathways in the development of mainstreaming genetic testing in Malaysia. Thank you, Suki.
Thank you for the very kind introduction, Breana. And thank you to the organizers for the opportunity to speak here today. So I think we've established very nicely from the two previous speakers how important genetic counselling is. Firstly, in the area of large cohort studies, anything that's to do with genetics or genomic studies, because you need to eventually reach to the people who would benefit most from knowing their information. But what I'm going to do then is to move on to how will we actually manage the access to genetic counselling, seeing that there's going to be such a burst of increased need for genetic counselling. So I'm going to use Malaysia as an example of a middle-income country, resource challenged as well, as most countries are, and as a ethnically and racially diverse country, we have different cultures, different languages, which in terms of genetic counselling becomes a very important aspect, because all of these have to do with how individuals make their decision and how they understand or perceive risk information based on their genetics. So we talk about a country like Malaysia, middle income, and this is probably most middle income and low income countries in the world. There is a shortage of clinical genetic services, shortage of genetic counsellors. So what is recommended, for example, is 1 per 100,000. I'm sure most of our countries don't meet that sort of ratios in terms of genetic professions. So in Malaysia itself, it's not just the lack of the numbers, but it's also the location. Most of the genetic services are located in the capital, Kuala Lumpur, and they do outreach programs, and there's one in Penang as well. So if we want to try and improve the access or try and reach as many people as possible, so there's several ways we can think of it. Do we want to just have more and more genetic professionals, more and more clinical geneticists, more and more genetic counselors? Do we embed them in each of the other specialty clinics? Do we do more telehealth? How do we make it more widely accessible? So in the context to demonstrate how some of these can be done, let's use an example of in oncology setting. And if, let's say, we would want to improve genetic counseling with what sort of methods can we use? So we can think of, say, embedding a genetic counselor in any of these other specialist clinic, could be neurology, could be oncology, but it would mean having to train a lot more. So this doesn't stop. I think in every country we need to train, we need to have more and more genetic counselors. That's really, really important. In Malaysia, we are short, we know that, but we are having an ongoing process. We have our own set up internal Masters of Genetic Counseling program. But what's important is to get the powers to be. So we need the, as Malaysia is under a health service, we need the health service to recognize it as a formal position, and this is something that we are working on through the society. So with, in a sense, recognition of these profession, then there will be budgetary allowance to have more genetic counselors in the service. What about using newer technologies? How can we tap on telehealth? And this is all post-pandemic. We're very lucky in the sense, well, not lucky, but it has pushed a lot of, well, not naysayers, but a lot of people who did not believe in telegenetic counseling to actually realize that we do not have a choice. We need to move into a lot more technology space when it comes to provision of genetic counseling. So having hybrid models, using telehealth platforms will become more and more important as we try and overcome geographical, logistical issues. So in Malaysia, we have already started quite a fair bit of telegenetic counseling, so this has been set up. And one thing interesting about Malaysia and also most of Southeast Asia, we are probably one of the most widely smartphone users. I think the statistics are 90% have WhatsApp. So it's something that can be tapped on. Now, the third one that has also been looked upon for maybe in the past 4 to 5 years is mainstreaming. And oncology was one of the first area where mainstreaming was looked at, and there was a lot of very positive outcomes from a lot of studies about mainstreaming. So we tried that in Malaysia as well. Very large national cohort by training oncologists or gynae oncologists and surgeons as well. So it's to really see whether it's safe to roll out mainstreaming when you train non-genetics experts. So the cohort was designed to look at psychosocial outcomes. So through this study, so initially, so you know that there are 3 sites of where genetic clinical services can be obtained. So with a mainstreaming program, in a sense, you then move a lot of this throughout the country. And you can see that we've had, because we were able to improve the access throughout the country, you can see that we will pick up carriers throughout the country as expected. I mean, it's, you know, if you have the service there, you will find the high-risk individuals. So you can see that it's throughout the country that we now have carriers. So we've shown that it is safe because there was no significant psychosocial impact. So you can train non-clinical geneticists to be able to roll this out safely in a sense. And it does improve access tremendously. So the coverage was so much better. Both clinicians and patients were satisfied. And one of the outcomes is that you then train the pathway for risk management as well. But bearing in mind, this is all done under a research study. So when you have a research study, you're providing a very safe pathway. Every part of the pathway is taken care of. What can we do then to make this into a clinical pathway? What do we need to have in order to sustain this sort of accessibility? So there are 4 main areas that we have to work on. So cost. So one of the ways that we try and get individuals to have access to tests is actually through research studies, because through research studies, they get the test for free. So many people will take up the test, right? So we know cost is an issue. The moment you remove the subsidy, your pickup rate will go down to 10 to 20% because most of the people will not be able to afford the test. So in order to sustain, so you want to run and let people take tests, you must find a way that we can work out the cost. So following the first study, we now have done a willingness to pay study because this helps us get some data. We can't also expect government to pay for everything. Maybe a shared cost protocol may work, but your governments will ask, who's going to pay what portion? So when we did the willingness to pay study, again, you have to stratify. The lower middle income, actually in Malaysia at the moment is only able to, willing to pay about 120 US dollars, and the higher income, twice of the amount, about up to 300 US dollars. But if we look at actual cost of genetic testing, that is doable, not too far, not too far. So what we also know that they are willing to pay, but it's not all that will still take the test if you give it to them. There's still other barriers that prevents them from taking a test. So when we talk about then if we want to implement, so even in the oncology space, let's say we want to move into another indication, let's say you want to move into breast, then there will be other challenges as well because your selection of who should have the test, your criteria is different. So it's again looking at how we can come up with tools as well to help with selection of who needs genetic testing the most. So we have done decision aids that are culturally accepted locally, but also for low literacy. So these are designed specially for low literacy. And also calculators in a sense. So in the space of breast cancer, for example, there are many established tools, for example, to pick up BRCA carrier. So you have BRCA Pro, you have Bodicea, but we've shown that those are actually not so accurate in an Asian population, so we have developed an Asian risk calculator. And this is really to help clinicians to ease them into finding those who are at higher risk without having to use guidelines that are perhaps requires a little bit more memory power. So moving on, the third part is then how do you sustain the mainstreaming in a sense? You will constantly have new specialists, new clinicians, new nurses that you need to train. You can't be running workshops after workshops. So you need to have a platform that is easily accessible. That means people can do it whenever they want, but they will get trained in a sense. So through University Malaya Medical Center, Prof. Aisha led the development of a mainstreaming course that is meant for surgeons and for oncologists. It's for breast cancer directly, but it is in a platform where it takes, I think, a total of 6 hours spread over a few weeks, but you can choose to do it at your own time. So these are the sort of things that is required if you want to sustain the continued development and training of non-genetic specialists. Finally, what then is the counselling care pathway? So remember, mainstreaming is very much the front end. You are approaching individuals, you are getting them to do testing. So now we know that throughout Malaysia, for example, we have all of these carers. So what happens to them for further risk management? What happens to cascade testing? What happens to managing their follow-ups and so on? You still need to have a genetic counselling pathway. Mainstreaming is not the only answer to improving access. It has to have a continued genetic counselling pathway. So what we are trying to move into is how best to use resources. So something like a whole and spoke model. So we have all our clinical genetics clinics right in a center as the main supervising overseer in a sense of the whole pathway. But eventually the goal is to have genetic counselors in all of the regions, right? We may not have them in every state, but North, South, East, West, and East Malaysia. And if we can do that, then there is a flow. So those who are involved in mainstreaming will have someone to refer to for the further care of the patients, the carriers, and their family members. So we have moved this. We are now working on policy papers with the Ministry of Health so that at least, without even creating the new post, but at least to have sessional posts for GCs in all of these places so that they can provide the continued counselling pathway for the mainstreaming model. At the same time, the counselling fraternity has to work very closely with the other specialists in order to start the MDTs. And we all know that the MDTs are essential when it comes to managing genetic conditions. So we do have an ECHO platform out of the University of Malaya as well, University of Malaya Medical Center as well. So this can be accessed. So you have the regular setup MDT, where all of your difficult cases are discussed, and those who are off-site in the mainstreamed clinics will then be able to access the support of experienced risk management teams. So in summary, Malaysia is an example of a low, for middle income country. How can we actually improve the access? So the constant complaint is always, there's not enough genetic counselors, there's not enough clinical geneticists. Yeah, well, we will keep building up, but as we build up, we all need to work together as a fraternity, tap the resources that you have, but we need to look at innovative ways of being able to reach our patients, and yet to make sure that the counselling is not at a lower level in a sense, that they still get good standards of genetic counselling. So the care pathway is very important, and it needs to merge with all of the methods of improving access to genetic testing and genetic information. So thank you very much. Oh, my apologies, I just forgot my acknowledgements. As you can see, there are loads and loads of people, many clinicians, because I think clinicians are the ones we really need to work with to understand better what is involved in counselling and what is necessary in counselling. So once again, thank you so much.
Thank you, Sookie. And could I just invite Yasmin, Marianne, and Sookie to join me in front for a question and answer session. So if you have more questions, please continue to send them into the Pigeonhole platform. So I'll start off first with a question for Yasmin. And the person says, thank you for the great talk. What is the current status of developing carrier screening in Singapore?
Thank you very much for the interest regarding the carrier screening in Singapore. So we've been working for the past couple of years in developing a carrier screening panel, and it is based on the data which emerged from the SG10K cohort, where we're able to look at the prevalence of recessive conditions, and it became apparent that carrier screening panels which were being ordered in Singapore weren't necessarily targeting the conditions prevalent in this population. So there's been quite a few people now involved in the development of a carrier screening panel which is more relevant to the Singaporean population. There's a clinical team who've been working with, we've developed an education tool which people will be able to look at and then decide if it's something that they would like to pursue. We've also been working with the laboratory regarding all the technical assays. And we are almost at the stage where we are able to offer the carrier screening test to couples. So we're looking at couples. We will be returning results to couples that are found to be at increased risk of one of the 12 genes on the panel.
Thank you. Our next question is very likely for Marianne. the question is, have we looked at which aspects of involving genetic counsellors increases uptake for research?
For returning results?
Yes.
Yeah, which aspects? Thank you for the question. We haven't actually looked specifically, but we have found that when you involve a genetic counsellor in the return of results, it does increase the uptake. Definitely in Australia, we have evidence for that. And the uptake was quite substantial. So there was one program where they were mailing patients themselves letters, and then in the envelope they just put a list of the genetic services, and people didn't understand what to do. And by embedding a genetic counsellor in that process and putting a free call telephone line that they could call, the uptake went from about 20% to 90%. So it's quite significant. I think it's about them having someone to talk to immediately when they get that letter. And I think it's also having someone who has the skills and expertise to talk to them about the information, what they can do about it, and also talking to their family about it.
Thank you. And the next question would be for Sook. The question is, how does the Asian risk calculator compare with tools such as the Manchester score?
So it was designed using and validated using local Malaysian data. So because it gives a score in a sense, it is more efficient. So you need to screen less to pick up more carriers. Manchester score puts a cutoff at 15% generally. So it would be even more accurate, but you will screen less. So in a sense, for bigger population, you probably will miss some. So it's not something that you can compare directly. So it was compared more with, say, a scoring system like Bodicea or BRCA Pro, where there is a scoring number, rather than a criteria list. And that was one of the reasons of building a scoring tool, because many clinicians have found it difficult to use a criteria list. So I think there was quite a lot of CPGs, even NCCN has a criteria list, and that was one of the things that the clinicians found more difficult to use.
Thank you. And this question would be for all three speakers. There seems to be barriers involved in students to be trained in genetic counselling. So some examples would be the lack of programs locally, as well as lack of awareness. And I think this is an international issue. Are there steps that can be taken to improve this?
Okay, I can take that first. So there are many ways to train as a genetic counsellor. And I would support anyone who is thinking of doing genetic counselling. So previously, you have to be on a physical location. You need to sign up for it's all a postgraduate course. So you need to sign up for a postgraduate course, do the master's, and you will still need to have professional training. So there are actually some of these courses that's moved to fully online and part-time. So you can still continue your work, sign up for a master's course. You will have your clinical attachments and so on, but you don't actually physically have to be at one location now in order to do your postgraduate courses in genetic counselling. And you can do it part-time, which means you can still have your income while doing a postgraduate course in genetic counselling.
I'll draw on that and add to it. I think there are lots of health professionals who do genetic counselling. It's not just genetic counsellors. And I think what the profession of genetic counselling needs to think about and articulate is what extra do they bring? What special skills do they bring to the table? And to me, the special skills are particularly around providing risk information and helping people make decisions, but also family communication. I think family communication is a real skill of genetic counsellors. And thinking about Sook Yee's talk on mainstreaming, one of my questions was, how do you think clinicians go with family communication? Because often that sort of conversation takes time. It's not something you can just do in 5 minutes, and clinicians are often very busy people, and that's why I was pleased to see the genetic counsellor pathway that people could then go along.
Yep, and just to add to both of yours, so in Singapore, so there is no specified program to study genetic counselling that's done outside. However, there is still opportunity to be involved, and we're looking at including what we're calling now genetics assistants or associate genetic counsellors, where they can come into the clinic and help, and perhaps they have a nursing background or another social science background. And so in that way we are involving more people. I think this is a great opportunity to see if there is an interest in developing this as a profession. I can't remember what else I was going to say. I think I was going to say something to you. Yeah.
I'll just add, in Australia there are 2 master's courses that you can do. One of them's online and the other one is in person. Yeah, and I know that there are a number of genetic counsellors in the audience here who I can see and say hi to, who've done the course in Melbourne or Sydney.
Yep, that's true. I think there's a lot of Singaporean students who uptake that too.
Thank you. So it sounds very much like we're still building the plane as it flies. But, you know, everyone here, you are really welcome to enter this conversation as well. And I'm sure genetic counsellors by nature, we are very open to feedback and collaboration as well. So to further the conversation, there is a question about the return of research genetic results to patients that have participated a long time ago. So how do they respond to this? So I think that this is in reference to Marianne's talk.
Most of them don't remember ever taking part in the study. And so when you speak to them, you take them through the study that they took part in. So you sort of have a bit of an introductory conversation, and you know, you say at the time that they did ask you and you said that you'd like to be notified, and we do have some information. You talk a little bit about what that information might be, what it could mean for them and their family. I don't know if it's Australians, but most people take it very well. They're curious, they want it, it's theirs, and they wish to know the information regardless of how long ago it was.
Yeah, I also have some experience with this as well, where when we're working with the external research institute, some of the participants had been recruited 10, 20 years ago. And so that it didn't come out of the blue, they were recontacted by a research coordinator who reminded them that they'd been involved in a research study many years ago, and then shared that we'd been doing some extra analysis regarding genomic information. Were they interested still in learning this? So they were kind of primed before then. They were contacted by me to see if they would want to then attend an appointment. So I did find with this cohort that perhaps the interest was perhaps slightly lower than those that had been recruited more recently, but at the same time, once they came to the appointment, I didn't notice any difference in how they responded to receiving the information.
Thank you. And just as a follow-up, Yasmin, for people who have positive results and decline confirmatory clinical testing, how do you manage that situation?
So in that situation, they receive a summary letter just outlining that this is a research result. We would still make recommendations regarding what health risks they're at, but we do also then outline that this needs to be clinically confirmed, that it's a research result, and that they're welcome to contact us at any time should they want to do this. Sometimes it's just not the right time to consider that.
Thank you. I'd just like to switch tracks a little bit now and check in with Sook as well. So the person has asked, so they've said, thank you, you've done a tremendous job in Malaysia. How do you convince policymakers and obtain funding to support the mainstreaming efforts?
I think the word is convincing. It's very difficult, but we have to try. So most policy makers require some form of data. So if you go up without any form of data, you will be struck out. So they will ask for some health economics data. You need to show, if possible, if you even have the health economics data that will include, how much lives it saves with the intervention and so on, that will be even better. But most of us struggle with health economics data because we don't have large enough cohorts, neither do we have, in order to show how good your intervention is with using counselling and testing, you have to have all of your risk management data. That means you need to know how many people have taken up the risk management strategies. But there are very good models that we can use. So the first thing is we need data. So, which is why for all of our genetics clinic that is ongoing, if we can get the data and put it into a analyzable format to try and get this data, then that will help. But advocacy is very important. So that's one of the main roles of the Genetic Counselling Society Malaysia as a neutral party. Meaning we put our hat as a neutral party. We don't belong to any organization so that there are less politics between agencies, between whether university, Ministry of Health, whether you're private, non-profit. So sometimes having that sort of neutral party will be important. So consider that from advocacy and a society point of view as well.
Thank you. To follow up with that, I think it's well known that genetic counsellors are not very well recognized. So do any of you have any sort of comments on how we can improve recognition for genetic counsellors or people providing genetic counselling?
I think, what I mentioned before about being able to articulate is what is it that a genetic counsellor brings to a consultation or a project, or what are the skills that we bring is a really important part of articulating this new and emerging profession. And I think, in Australia we struggle with it too, like in Malaysia and in Singapore, that genetic counsellors are not recognised. We are a professional organisation, but there's still a lack of recognition. So I think we need to just articulate what it is that we do and what value we add to a team.
And also the integration of genetics now is expanding hugely. So we used to have just certain particular clinics and we were working just amongst ourselves, but now as we've had an example of mainstreaming, as we're embedded into different institutes within the hospital, we're now doing population screening. So I think this is also increasing the awareness of the role of the genetic counsellor and the integration of genetic counselling practice in clinical care.
So I'm going to ask the audience again, how many of you have worked with a genetic counsellor or used a genetic counsellor or seen a genetic counsellor?
Don't be shy.
Okay, not too bad. So you see, even in this forum, which is genetics and cohorts, many people haven't actually had direct contact with a genetic counselor or used genetic counseling. So I think with an increasing awareness, with more people having access to it, they will realize that that is actually a very important part of the whole pathway of using genetic information. So I think we always like to, it's like akin to having air conditioning. Before you have it, you didn't know how good it was, but once you have it, you can't live without it. So we encourage everyone, if you haven't had access, try, work with a genetic counselor, have a session yourself, and realize what is actually in the pathway.
Thank you, Sook-yi. I think you are one of the best people to give that plug. All right. This has been quite upvoted, so it's a question for Mary Ann. How do the counsellors track patients on the platform as they progress on the care pathway, such as when they're navigating the healthcare system? Does the platform itself track cascade testing uptake?
Currently at the moment, no, we don't track cascade testing. Once we know that they've reached the clinical genetic service, and when I say reached, once we know they've had an appointment, we sort of break the chain then and hand them on. One of the things we are looking at doing is following up the cascade testing, and also following up what happens to people once they get to the clinic, because as someone mentioned before, we have had some people who get to the clinic and then decline confirmatory testing. So there are lots of places along the pathway that people might opt out, and it's important to understand that, and we're collecting that data at the moment.
Thank you. Well, I chose this question because I think it's quite interesting. So, do you think genetic counselling can be privatised to achieve economies of scale?
In Australia, we already have a large private practice genetic counselling workforce, primarily in prenatal. A lot of genetic counsellors working with obstetricians. In cancer genetics, there's genetic counsellors in private practice or genetic counsellors working in oncology practices. And there's also genetic counsellors who work privately in reproductive carrier screening. So I think it's a great idea, and I think if people can afford to pay to go and see a genetic counsellor, it takes the burden off the public system, and that then frees up spaces for people who can't pay to actually be seen. So I think there is value in having a private sector genetic counselling profession.
Yeah, I agree. And even in Singapore, there is now genetic counsellors practicing in the private space as well, in oncology, cardiology. I'm not so sure about prenatal. And I'm just finding in my own clinics, the wait list is just growing and growing, and particularly in cardiology. I'm now getting, daily requests from cardiologists just saying, can you just push the patients in? It doesn't seem like anybody is just going through the usual booking system, so that's really challenging to try and find spots that don't exist. So yeah, I think that, that's possibly a way of alleviating some of the demand in the public system as well.
Yeah, I think it's not privatizing genetic counselling per se, but it's really more of the other way of thinking that in private healthcare, if you are using any form of genetic tests or genomic screening, you should already have in plan what you're going to do for the pre and post counseling. So if it is a private entity using genetic information, you should already have a genetic counselor on board. So there should be more positions or in whichever, whether it is a private clinic or whether it is a private laboratory, if you are selling a test, you should have a genetic counselor or genetic counseling embedded in the system. So it's not about privatizing genetic counseling per se, it's about being, but in the private sector where the use of genetic testing is increasing a lot more rapidly than in the government sector because of cost and so on. So it is the private sector that really needs to put this in their pathway.
Thank you. And one might also argue that, you know, where there's demand, there will always be services popping up, both in the public and the private spaces as well. And so I just wanted to ask this question to the panel of whether there have been any comparisons on return of results by genetic counsellors as compared to other healthcare providers such as primary care physicians or other allied health professionals.
So I think there has been comparison based on some of the mainstreaming studies. But again, these are, like I said, because if it's in a study, it is very well structured. So whoever who is going to a non-genetic specialist will also eventually have the back or the support of a genetics team in all of the reports, right? So the thing is, evidence-wise, there isn't very much difference. So that's why it says mainstreaming actually works quite well. But it's in a clinical setting, then that one might be different. Because primary care, for example, they would have the result, but if it's a bit more complicated in a sense, well, one thing is family testing, but the other thing is all interpretation of, say, a VUS or even a unexpected positive result. So the mainstreaming so far hasn't really provided enough pathways for that. So it is actually something that really needs probably a lot more data on in how to translate it clinically.
And I'd add to that I think it depends on what the result is. I think that a primary care physician can manage some results, and if you think about in Australia, familial hypercholesterolemia is managed by primary care people. In America, every year they do an audit, and the data does show that results given by non-genetic health professionals are more likely to be given erroneously than if they're given by a genetic health professional. And that's particularly around the VUSs that they don't understand VUSs. So there is data out there showing that. And it has unfortunately resulted in some difficult challenges, which are now in the courts being sorted out in America. So there is emerging data, but I agree with Sook that if you actually have a genetic counsellor who's available as a resource for information like the mainstreaming, it can work really well.
And there's the other, I guess, aspect of time as well. So it does take a lot of time to return results if we want to talk about the personal implications as well as the implications for family members. And I do wonder if, you know, general practitioners and specialists in their busy clinics just have that amount of time. In the genetic counselling clinics, we are very fortunate that we do have more time available than, say, some of the specialist appointments, which only run for 10 or 15 minutes. So that's another component. I do think that there is a role, but as Sook, you suggested, that comes with a lot of training as well and a lot of support. Yep, so these are things that need to be considered.
Thank you. And so we are running out of time. So maybe what I'll do is just get each of the panelists to share with the audience here today what is the one biggest takeaway that you'd like everyone to have with regards to genetic counsellors and the role within the healthcare system?
You can't do without them. You must have them. No. They bring added value. They do bring added value, and they bring a specific set of skills and knowledge that other healthcare professionals may not have. And so I think it's really important that they are acknowledged and recognised as part of the multidisciplinary team. And I think once that happens, people then learn about what genetic counsellors do and understand that the value that they add.
Yeah, I feel that we're quite appreciated as a profession. I've never been in the situation where I've worked with healthcare providers who haven't felt that there is a role for genetic counselling in their particular practice or clinic.
Yeah, I think we are in very exciting times now. We can do so much using our genetic profiles. So let's try and reach as many people as possible, help them understand. So genetic counselling is very important in that pathway.
Thank you. So to everyone here, thank you for being part of our journey as well, because we definitely do not practice in isolation. And I know there has been a massive amount of upvotes with regards to how to become a genetic counsellor. Please feel free to come approach any one of us who are genetic counsellors. We'll also point you to friends in the region where you are based. That is something that we can have a conversation outside of this forum as well.